Good evening, everyone. My name's Rob. I'm the Clinic Director here at Care Fertility London. We will be continuing the presentation in about 5 minutes' time. There's a few more attendees left to join us, so please bear with us. And Mandy and myself will speak to you in a little while. Thank you for waiting, everyone, and thank you for attending a webinar tonight. We're here to talk to you about infertility and when to refer as a GP. Dr. Mandy Tozer here will be hosting the evening with you. I'll talk a little bit after Mandy's just introduced herself to you. So Mandy, would you like to introduce yourself?
Yeah, so I'm Dr. Amanda Tozer and I'm Medical Director here at Care. And I've been doing fertility now for since 1997. And so I have a lot of experience in fertility. And actually, this is one subject that I still find really difficult to answer. So it's a difficult question. But hopefully, I'm going to give you some guidance of when you should do test investigations and potentially refer patients to the fertility clinic.
Super. So myself, I am a scientist. I've been here for 12 years. I trained with Care initially 15 years ago and then moved down to London and set up the IVF laboratory here. And I've been here ever since. Mandy has been with us here as the medical director now for just over a year. I'm very pleased to have her, and I'm hoping you all will be able to gain some very valuable insights from her as to all those patients you're going to be seeing in your clinics who are struggling with getting pregnant. And hopefully you'll leave here knowing a lot more about infertility, and most importantly, when is the right time to actually refer to the fertility clinic. Anyway, without further ado, let me press on. Quickly give you a little bit of background as to Care itself. Care is now the largest independent fertility provider in the UK. It started off as 3 clinics up in the Midlands and the North, and it's slowly expanded down here to the south into London and Tunbridge Wells. We're based at the London Clinic, which is just close to Regent's Park, up from Baker Street Tube Station. I'm sure you see patients coming to your clinics from all over London, whether it be north or south or east. You can refer to any of our clinics. The pathways of referral are identical. So hopefully after tonight, you have a bit more information. If you do come across a patient tomorrow or in the next couple of weeks, months or years, you will have far more information to know where to refer them on to. So as a group of IVF clinics, what we provide is a whole host of different kinds of fertility treatments. From the most basic, where couples are just struggling to conceive, we will do, or Mandy will do, a few investigations just to see if there's any obvious underlying cause of infertility, and we can treat them very simply using timed intercourse, maybe a bit of ovulation induction, which is giving the patient a few drugs to stimulate the ovaries, and then they go home, have intercourse, and hopefully conceive by that method. Then we talk about something called IUI, which is down at the tip of the bottom of that tail. An IUI is insemination. It's a slight step up from couples going home and having timed intercourse. It's the process whereby we stimulate the patient's ovaries. The male partner will come in, depending on his sperm quality, which is something Mandy will talk to you about. And we'll just do an insemination into the top of the uterus when ovulation is being primed, and they can conceive that way. That process is done within the clinic here. If that's unsuccessful, or if there's other factors, such as the man having a low sperm count, or the female doesn't have a very active menstrual cycle and they need some artificial governance over that, then we can do IVF. That's the process whereby we prepare the body, get the ovaries to respond to some gonadotrophins, some simple drugs to increase ovulation and follicular development, and then we collect the eggs from the ovaries and we fertilize them using the partner sperm or donor sperm here within the clinic, and try and create an embryo, which the clinicians here pop back inside the womb, and we try and conceive a pregnancy in that manner. Then there's lots more interventions we can make as scientists and doctors. Vitrification is a form of freezing embryos. There's lots of additional techniques in the lab called time-lapse embryo imaging, immunology tests, genetic screening, but maybe we'll save that for another night. Tonight is about yourselves. It's about learning a bit more about infertility and when the time is right for you to refer. So let me pass you on to Mandy. She will carry on the presentation.
Thank you. So I need to make sure.
Just bear with us one sec, a few technical difficulties. Just press the left one to continue.
Thank you. Okay, yeah. So I'm going to talk to you about when to refer for fertility investigations. As I said, this is not an easy thing. So Well, what information do we have? Well, not a lot. Of course, NICE do recommend that any woman of reproductive age who has not conceived after a year of unprotected intercourse, in the absence of any known cause of infertility, should be offered further clinical assessment and investigations together with their partner. And say that's straight out of the NICE recommendations. And they also state early referral to a specialist should be made if the woman is older than 36, or if there's any clinical cause or something significant in their history. Well, that's all good and well, and but you've got to make some kind of assessment yourselves. And for me, I like to take a common sense approach to it. And when you're seeing a couple, and I absolutely appreciate in general practice, you've got very little time to evaluate the couple. Here in the clinic, I have the luxury of 30 minutes to an hour to do this. But of course, for you, you've got to make quite a rapid assessment of the couple. So I'm going to try and point out the most pertinent points, the things I think are most important to get out of the patient. So of course, that your evaluation does need to look at the length of time the couple have been trying to conceive. You need to look at the medical history for both of them. And of course, you may have a lot of that information already. Their social history, the age of the woman is really important. And you also need to take into account the couple's anxiety, their stress, and their desire to become pregnant. Some couples just want to know if everything's okay. Great, that's lovely. Other couples are absolutely insistent they want to get pregnant tomorrow. So when it comes to their history, one of the most important things is how long have they been trying to conceive. We know, again, from NICE research that 90% of couples will conceive within the first 2 years of trying, with 80% in the first year. And we know that if couples have been trying for more than 2 years, they're more likely to need some form of fertility treatment. And certainly if they've been trying for more than 3 years, they are more likely to need IVF treatment. I'm going to deal with the men first. I usually deal with the women first, but I'm going to deal with the men first this time. So sort of things that you're interested in when talking to the man are, first of all, does he have any problems with getting an erection or an ejaculation or any problems with intercourse with his partner? So, these are not easy questions, and you may have some information already in the notes. You also need to know if he's got any medical problems. And there are certain things, of course, that we know are associated with ejaculatory problems and can affect sperm. We know that epilepsy has been associated with reduced sperm parameters, so reduced sperm motility and sperm numbers. We know that vascular problems can affect the ability to get an erection. Depression has a massive impact on libido and an ability to get an erection, previous treatment to the prostate. Can cause erectile dysfunction, retrograde ejaculation, and of course we know diabetes can have an effect. So these are sort of the medical problems that may cause problems and therefore alert you to do a sperm test earlier, or perhaps referral to a psychosexual counsellor or a urologist. The other thing that's important in the man's history is, does he take any medication? And interestingly, there are certain drugs that may affect sperm quality. Now, these are not absolute, but these are some of them. Calcium channel blockers, such as nifedipine. Now, it may be that a man's going to have a normal sort of analysis whilst they're on nifedipine, but if they are on these drugs, there may be an associated reduction in sperm quality, and therefore it's important to send somebody off for a semen analysis sooner than later. Of course, any history of trauma to the testes or pelvis is also important to know about. Does he have a history of undescended testes? We know that if the testes aren't brought down into the scrotum by the age of 2, there's a good chance that actually spermatogenesis will not occur. In other words, he'll have azoospermia with no sperm there. Has he had any operations on his pelvis or genitalia? Again, you may have this information already. Interestingly, is mumps. We know that orchitis is one of the commonest complications of mumps in postpubertal men. And we know that orchitis affects 20 to 30% of those cases. Now, 10 to 30% of them are bilateral, and it's those cases where it's bilateral that mumps orchitis can cause subsequent problems with sperm and certainly reduction in sperm number. Again, any history of that, they should be referred for a sperm test.
What I would say to you all, if you have any questions whilst we're going along here, feel free to ask them. You can type a question into your bar up on your side. We can't see it at the moment. I can quickly just check and see if any questions have come in at the moment. So if you do, and we do have a question just here. So let's have a little look and see if we can read that. Can a woman with low Müllerian hormone have ovulation induction?
Okay.
Was the first question.
Okay. You can't hear. Okay. I'll try and speak louder, and hopefully I can. You can hear me.
Oh,
Sheila.
She says she's okay now.
All right. Okay.
Glad you can hear us, Sheila.
Okay. Now with the low Müllerian hormone, I'm going to come on to the female bit, and I'll tell you the significance of anti-Müllerian hormone when we come on to that, if that's okay.
Super.
Okay.
And we have another one here. Is the reduction in sperm quality with medication temporary or permanent? Good question.
Yeah, it's a good question. It's temporary. The wonderful thing about spermatogenesis is that it's ongoing. So unlike in women where we're born with all the eggs we're ever going to have, spermatogenesis is ongoing, and therefore you stop the medication, and there's clear evidence to say that the sperm parameters return to normal.
Super. Okay, thank you for your questions so far. We'll come back and read those again in a couple of slides' time. So if you have anything, please feel free to engage with us when you like.
Okay. I'm just going back to the slides. Oh, Rob's going to take me back to the slides. I'm going to take you back to the slides,
if I can get you back to the slides, Mandy. Right, just bear with us one moment.
If you click on the back, it'll probably come back up.
Oh, there you go.
Yeah.
Super.
Good. So, okay, down. Right. Again, coming back, still staying with the man, you know, is there a family history of infertility? Has he fathered any children? And then you come on to the sort of social questions. Does he smoke? We know that smoking has quite a significant impact on sperm. And of course, men should be advised to stop smoking. How much alcohol does he drink? Again, nice to recommend 3 to 4 units a week for couples who are trying to achieve a pregnancy. And also recreational drugs are worth asking about, because there's no doubt that recreational drugs have an impact on fertility, either reducing sperm count. Cocaine, we know, can lead to erectile dysfunction. And of course, anabolic steroids can lead to testicular atrophy. So, other things, is he overweight? And occupation. Occupation is an interesting one, and there's some clear evidence, certainly, to show that sitting down for more than 6 hours a day can reduce sperm quality. And exposure to certain things like solvent, heat, radiation can also have an impact. Now, again, these things are reversible, and so you know, things can be improved. So it's important to ask these questions, because for men, you know, they can change their lifestyle, they can change things, and it can improve their sperm count. So what can we do in form of tests? So what are you going to refer the man for? Well, it's really for a semen analysis. And again, there's no clear guidelines when you should send a man for a sperm test. But my feeling always is that, certainly, of course, if there's anything in their history, then absolutely refer them off for a sperm test. Things relating to lifestyle changes, we should be talking to them about anyway, because even if the sperm test is entirely normal, we do know that things like smoking can have an impact on subsequent pregnancy rates, even when patients are going through infertility treatment, because we know that smoking can affect the sperm such that it can affect embryo quality. So my recommendation actually is usually to send for sperm tests anywhere between 6 to 12 months of trying. And I know that sounds quite early, particularly if they've got a history of something, and certainly after 12 months of trying to conceive, if they've got no medical history or anything indicating they have a problem. Of course, if the test is abnormal, it may be that that's just a variable things. As we know, semen analysis are very variable, sperm counts can be variable, and sometimes need to be repeated. But you know, if it is low, sperm count's low, or there's an issue, then send straight to the fertility centre for further assessment.
What I would say with regards to the semen analysis is what we're not going to do tonight is talk about results and assessing those and interpreting them.
Yeah.
If you or the audience tonight feel that there would be benefit from you understanding that a bit more and us talking through as the professionals a bit more about interpreting those results, then please leave some feedback about the presentation. We can do a follow-up presentation to this one, looking a bit more about the investigations, the kind of things we see, and talk more about the IVF process in general. So yeah, please do feedback after this, but tonight we won't be talking any more about the semen analysis side of things, unless we do have a particular question about it.
Take that off me. Thanks, Rob.
Let us quickly check and just see if, oh, where's that little pointer gone? Where's it gone? Sorry, 1 moment. Apologies, just 1 moment. We will come back to you just now. Let's have a quick look for the questions, see if there are any. Okay, so Mandy, antidepressants, do they have any effect on male fertility?
Well, the antidepressants really are your SSRIs, so things like paroxetine, and they have been shown to have an impact on sperm quality. Again, this is reversible. And of course, you know, associated with depression may be have an impact on libido, erectile dysfunction, of course. So there are sort of questions to ask, of course, if they're, you'll know if they're on SSRIs, but if they have any issues with libido, with erectile dysfunction, and then I would send somebody for a sperm test if they're taking SSRIs sooner than later.
Okay, we have a question here from Dr. Agarwal. Just wanted to check, is it 3 to 4 units of alcohol per week rather than per day for men trying to conceive?
Yeah, well, yes, it is. I mean, NICE recommends 3 to 4 units per week. Of course, this is less for women. It's 1 to 2 for women, but yes, 3 to 4 per week.
And we have a question here from William O'Driscoll. Given how tricky it can be to get a mid-luteal progesterone in a patient with irregular cycles, how useful or needed is it? Yeah,
and again, I'm going to talk about female fertility and the use of mid-luteal phase progesterones and in a minute. So perhaps I can answer that one in a few minutes.
Yeah, absolutely. And what is the normal minimum sperm count?
Do you want to answer that one, Rob?
Yeah, the per million per mil is, I think, the World Health Organization said 15
million per mil. Yeah.
We perform semen analysis here in the clinic. We don't provide any NHS treatments here. The cost for semen analysis is £150. We're more than happy for patients to self-refer to us. So if this is something that you feel your patients may benefit from, if they don't want to wait for the NHS, then by all means, please feel free to refer them on to us. Just bear with us 1 sec. We just need to get back to our presentation deck, which I've just managed to lose. I'm hoping you can see it at the moment. Just hold on 1 minute. We'll be back in just 2 seconds.
Back up.
Okay, everyone. Sorry about that. Slight little technical difficulty. Being a scientist and a doctor, we are not the most familiar with IT. Let me just take this away, Mandy.
Yeah.
And let's just close that one off.
Yeah.
And we'll go to that one,
right.
And we will click.
I need to go back to about 12, I think, on the left-hand side first.
So, how do you start the presentation? Down there in the corner.
Yeah, that's
right.
Okay. Yeah, go back right up to the top. Oh, that's
There we
right.
go.
Okay, right.
Right, over to you.
So here we go. So for the woman, again, you know, some women do have problems with intercourse, and some people do have vaginismus. It's not uncommon. So do need to ask again to make sure they're having penetrative intercourse and how frequently. And then, of course, most importantly, you've got their menstrual history, and we know that in women who are having regular cycles, they're usually associated with ovulation. And I think you can reassure women that if their cycles are nice and regular, they're most likely to be ovulating. However, of course, if their cycles are irregular or they're not having periods at all, then of course they could have polycystic ovarian syndrome or some other condition, but clearly they're going to have a fertility issue then because they're not ovulating on a regular basis or at all. Of course, heaviness of menstruation can reflect or infer maybe fibroids in the uterus. Pain of menstruation can mean there's some endometriosis. Pain with intercourse can mean there's endometriosis. But comorbidities, fibroids, endometriosis are not as common, but you should just be alert to the fact, there may be something else going on here. There may be something that may cause infertility that warrants an early referral for tests. Of course, we need to ask about previous pregnancies. Have they had a previous miscarriage? At least you know if they've had a previous miscarriage. We know that the sperm can get to the right place, can fertilize the eggs. There's a lot of positives to be taken from that. Have they had a predetermination of pregnancy? Well, that can be associated with pelvic infection, tubal disease, and again, this may indicate a cause of their fertility problem. Have they an ectopic pregnancy? Again, that might say this is tubal disease, and they need to have a history of salpingogram or tubal test performed sooner than later. Again, pelvic inflammation may indicate tubal disease. So you'll have their past medical history, I'm sure, in front of you, and any previous operations that have been in the pelvis that may have caused adhesions or infection are also worth noting, because again, this might be a cause of their fertility. Again, similar to men, is the woman overweight. We know obesity can cause menstrual disorders, and we know it leads to a reduced rate of fertility, both naturally and, of course, with fertility treatment. And there's no doubt, in accordance with NICE again, that all women should be encouraged to lose weight. And we know, of course, that for NHS funding, women need to have a BMI less than 30 to have funding. Now, we don't do NHS funding here. Of course, we do in our other care clinics. And we need to avoid obesity anyway, because we need to avoid obesity-related pregnancy problems. Does she smoke? We know smoking has an impact on a woman's ovarian reserve, and we know that women who do smoke can have an early menopause. So again, women should be encouraged to stop smoking. Women are recommended to only have 1 to 2 units of alcohol per week in accordance with NICE. And exercise is important. Lots of women, particularly in London, seem to exercise a lot, excessively, and can in fact put their body mass index so low it stops them ovulating. So you need to talk to them about that as well. And medication. Medication doesn't have the same impact as it does on sperm, but of course we need to know for trying to get pregnant.
Right, I'm sure that you would have had a few questions about that. Should we quickly check and see
absolutely.
If anything has been asked by our audience?
It may be that they're going to ask more about tests, but we can see.
So, Dr. Who is this? It's Dr. Selvan. You asked that about the sperm count.
Yeah.
Dr. Agrawal just said, just wanted to check that we'll get a copy of the presentation slides sent out to you at the end of this. Absolutely. Everyone who has signed on tonight and is an attendee will have access to this presentation.
Yeah, of course. Okay. So I'm going to talk now about tests. Well, as I said, young women who've got a regular cycle are most likely to be ovulating, and I think you can reassure them. Coming to that middle luteal phase progesterone question, well, of course, if a woman has a nice regular cycle, it's quite an easy test to do, and the test needs to be done 7 days prior to the woman's bleed. So if they have a 28-day cycle, it should be done on day 21, that's mid-luteal. If they have a 30-day cycle, that should be done on day 23, and so on. And it is really difficult if the woman has an irregular cycle to get the timing right. And you can end up doing multiple, blood tests to try and see if they are ovulating. So it is of value, I guess, to show them, yes, you have a regular cycle and absolutely you are ovulating. But I think, a lot of women now are doing things like LH testing. I'm going to talk about that in a minute. And certainly in women who have an irregular cycle, I think it's really difficult to pinpoint the right time. And you can often do a blood test, it comes back as abnormal, and then they are absolutely stressed that they're not ovulating, and in fact they are, you just do it at the wrong time. If a woman's got no bleeds at all, or really very infrequent bleeds, then it's really important to try and establish, is the ovary still working or not? What sort of problem is this? And so doing an FSH, LH and estradiol is of huge value, because then you can distinguish between hypothalamic, hypopituitary, hypogonadism, which is what we see when people are very stressed, or they exercise, or they're anorexic, as opposed to having polycystic ovarian syndrome or ovarian failure. So those tests are great for irregular or no bleeds.
And what stage of the cycle do you do those?
Well, so if they've got no bleeds at all, just do them. If they've got very irregular bleeds, you can try and catch it on their first day of their bleed or second. But again, I just do them if they hardly got any bleeds, otherwise you're waiting forever to do a blood test. Again, it comes back, if you're having a nice regular cycle, to do an FSH test, I'm going to come on to you now, can indicate ovarian reserve, but it's an ovarian reserve test then. So the key thing about ovarian reserve tests, and women seem really keen to have these done these days, but what information can you really get from an ovarian reserve test? It absolutely doesn't tell you whether or not a woman's going to get pregnant, and it really doesn't. And you do a test such as an AMH test, which is a good test for an ovarian reserve. If it comes back as low, you actually get panic. What's going to happen to me? And trying to answer that question, I think somebody asked about a low AMH test and ovulation induction, then absolutely you can do ovulation induction in women with a low AMH test. So lots of women with low AMH will conceive naturally because it does not reflect the quality of their eggs, it only reflects the quantity.
Yeah.
It's really important for us in fertility clinics to know the AMH because it gives a really good idea of egg numbers we might get for IVF treatment. But even for us, success rate of fertility treatment is still age dependent. Okay. And other tests of ovarian reserve, an FSH test can be done, and that, Rob, should be done on first, second, or third day of the bleed because that's the best time to do that.
Okay.
An AMH test can be done at any time in the cycle at all, so it's not determined by the cycle. And
do you need to check if these women are on any form of contraception before they do any of these tests?
You do. So obviously, if a woman's coming and they say, right, I want to get pregnant and I'm going to stop the pills soon, do you think I need any tests doing? Then an AMH test you should do when they're not taking the pill because it can actually suppress. At one time it thought it wasn't, but it can suppress your AMH level. So tests such as prolactin and thyroid function testing are only of value in women who don't bleed or have very irregular bleeds and should not be done in women who have a regular cycle.
Should we just check for some questions?
Yeah,
and just see if anyone had anything to ask about those. So,
So, do exercise have an effect on ovulation? No, they don't. We don't believe they do. And in fact, lots of women are on antidepressants, and they are, but they do not appear to have an effect on the ovulation.
So, me not being a doctor, what's an SSRI?
It's a particular type of antidepressant.
Okay, fine. And Dr. Easy also had had another question. She saw a couple who have been trying to conceive for 6 months. Is it too early to start investigating as the guidelines state 2 years? Does this depend on the age of the
So again, it depends on the age. And again, if they're over 36, according to NICE, look, I think it depends on a number of factors that we've gone through already. For me, in some ways, when somebody's very young and they've been trying for over 12 months, I'm more worried about those patients, in fact, because we're always saying young people should get pregnant, and if they're not, why not? So I think, for me, women or couples are really anxious. They want to know what's going on. So basic tests for me, once you've said, right, are you having regular cycles? Are you having frequent intercourse? I would absolutely do a sperm test, because I think if there's a problem with the sperm, that takes the couple down probably a treatment route. And certainly, I would consider doing an early pelvic scan to make sure there's no pelvic abnormality. Because really what you want to rule out, is there anything obvious or any obvious reason why this couple can't get pregnant? And, you can get that kind of information, I think, from a sperm test, from a scan. So I think, 6 months trying as a couple, I'd be anxious, and women are getting more and more anxious. So for me, yeah, I'd get on and do some investigations, no word.
Super. So we've got some more questions coming through at the moment. So we've had a question here saying, when AMH levels are low, why are those patients refused NHS treatment?
Now, the refusal to treat patients in the NHS is cost effective, because when the AMH is low, the egg numbers or the eggs that they collect from the cycle of treatment is also very low, and that patient may need to go through more than one cycle. So it is purely based on finance when it comes to being refused for treatment in the NHS.
Super. And one final question before we crack on again is, Mandy, you mentioned regarding LH or OPK testing. How helpful / accurate are these?
Okay, so I'm going to go on to my next slide, because that does answer that question.
Okay, I don't know if this is anything. How closely does the LH surge correlate to ovulation?
Okay, yeah. So my next slide.
Okay, should we go on to the next slide?
Do please. I think it's my next slide. It might not be my. Oh, it should be my next slide. I think. Here we go. So apps and smiley
faces. Apps and smiley faces.
Yeah.
Perfect.
Okay. Well, of course, women are using apps more and more to monitor their cycles, and I love them. I think they're really good because one, when you ask somebody, do you have a regular cycle, they hopefully know, because they go, yeah, it's on my. I've got this app. It's fabulous, and it's monitoring my cycle. So they know their cycle is nice and regular, and the app is picking that up, and the app is saying, right, this is your fertile time. Wonderful. Okay. Even for people with slightly irregular cycles, maybe they're a bit longer, say they're like between 28 and 35 day cycles, it works for them too.
Yeah.
Now, with the LH testing, there are lots of different types of LH testing that you can do out there, lots of different kits. So, and one of the common ones used now is something that gives a flashing smiley face and a static smiley face. And when people started to talk to me first about this, I think, oh my gosh, what's going on here? Because I'm so used to just using the original old-fashioned 2-line LH testing.
Yeah.
But I think that they are of value. And when we get a positive LH surge on those tests, it is highly predictive of ovulation. The other flip side to it is, if they don't get an LH surge, are they not ovulating? And that is not true.
Okay.
So sure, some people may not be ovulating, but for some women, they have a very narrow LH surge. And actually, I advise those women, if they're not getting a positive surge, to do the urine testing twice a day, because they may be missing it. And if they're still not getting an LH surge, then I probably would absolutely try and do a mid-luteal phase progesterone level. Now, the smiley faces, flashing smiley faces, of course, reflects increasing estrogen levels as the so-called follicle with the egg net is getting bigger. It puts out more estrogen. You need to have that static smiley face for the LH surge. So you can get a flashing smiley face reflecting nice high estrogen levels, and some women don't get the static. Now, that's difficult. And again, I would probably be inclined to do a mid-luteal phase progesterone then for in surgery. Of course, here I would scan somebody through a cycle to see whether or not they're ovulating. Yeah. And that's easy because I've got the facilities to do that. But in general practice, to try and reassure the patient that there's a good chance they are ovulating, then I'll do a progesterone.
Absolutely. So we've had one more question just come in while you was talking, saying, do you recommend ovulation tests to your patients?
I do. I think I do as an initial thing. Some patients get obsessed with them, and I say, look, try LH testing, maybe 1 or 2 months, and if you're getting a lovely LH surge, then fabulous. Don't keep repeating doing them, because they can also actually cause a lot of stress.
Yeah, absolutely.
So yeah, sure. I like LH testing. I think it gives the woman a lot of control. They know what's happening and they can time intercourse. Yeah. But you know, for most people, it's going to be positive in those women who have nice regular cycles and kind of they're going to be, you know, ovulating anyway. But I do advise and say, yeah, do some LH testing.
Super.
The next thing, of course, is a pelvic ultrasound test. So when should you refer for a pelvic ultrasound scan? Well, I think this is a really, really useful test because the pelvic assessment helps you to, well, first of all, it looks at the uterus, it looks at the ovaries, you can rule out fibroids, you can rule out swollen tubes, hydrosalpinges, you can see cysts, you can see some endometriosis, and you can also, of course, do an antral follicle count to look at the ovarian reserve. So it's a really, really useful investigation. The right time to refer for a scan or to do a scan, but of course, if there's anything significant in their history, heavy periods, painful periods, then I would refer sooner than later to sort of check it out. Now, interestingly, of all the scans that we do, unless there is something suspected, they've got some pain or something, they're highly unlikely to find anything. Mm-hmm. Most scans are going to be entirely normal, but it's hugely reassuring to the woman if you've got a normal scan finding, and you can reassure them saying, look, nothing wrong with the uterus, ovaries look fabulous, no cysts, good antral follicle count, and they feel very reassured by it.
Absolutely.
Tubal patency. Now, of course, as a GP, you know, is it appropriate to refer, or when should you refer for a tubal test? And of course, you can send patients for a hysterosalpingogram. I think some GPs have the ability to send patients for a HICOSI, that's like hysterocontrast salpingography, to look at tubal function. And sending women off for a tubal patency test, I think, is really important. Of course, if they've got anything again in their history that might indicate they have a tubal blockage. But if a woman, if there's nothing in their history, you don't suspect any tubal factor, I would sooner do a sperm test first to have a look at that before doing a tubal patency test, because if there's a problem with the sperm such that they might need fertility treatment, then they may not need a tubal patency test anyway. So, you know, why put somebody through an unnecessary test? I like a HICOSI better in some ways than a hysterosalpingogram, because you also get an ultrasound scan of the pelvis at the same time, so you get a lot more information. However, more skill is needed for that. It is in some places more costly than a hysterosalpingogram, but either procedure would be fine.
Super. So we've got some another question that has just come in, or a couple. So let's quickly run through these. Sheila Matthews, I thought the ultrasound scan was poor at picking up endometriosis.
Sheila, you're absolutely right. It is fantastic at picking up endometriosis in the ovaries, in other words, endometriomas. It can also, however, be suggestive, say the ovary is not in the position you expect it to be, it's stuck behind the uterus. So it can make a suggestion that there's something happening in the pelvis associated. But absolutely right. The best way to diagnose endometriosis is undoubtedly by laparoscopy, but it's great at diagnosing endometriosis within the ovary.
Super. I hope that answers your question, Sheila. Dr. Agarwal has asked the antral follicle count in scan reports is rarely commented on at BARTs. Is this more commonly commented on at other hospitals? Now, you're perfectly placed to answer this question.
Well, yes, because I was at BARTs for many years, from 1997 to 2015. It's interesting, and I think it depends who does the scan. So as a GP, of course, you're referring into for a scan, and at BARTs, the ultrasound department will do that scan. So very that scan's not performed in the fertility centre. Unless specifically, and you can specifically ask for a comment on the antral follicle count. So if I was sending something for, and I wanted a specific fertility scan, I would say on that, please comment on the antral follicle count, because it's an easy thing to do. You don't have to be skilled in fertility ultrasound to do it. And in fact, most of the sonographers at Barts will be absolutely perfectly capable of doing that scan. Yeah, I think, you know, as a fertility, if you're referring for a fertility scan, then I think it should come back with an antral follicle count on it, and I think that should be a routine thing that is reported.
Something hopefully you'll benefit from, and what's a request when you're putting a scan referral in. And last question from Dr. O'Driscoll: how long before refer for tubal? So if there's a history in there of for a tubal patient, yeah.
You know, well, if somebody's had a pelvic infection, you've got to wait, I would say, at least 3 months following treatment for pelvic infection, for pelvic inflammatory disease, because of course you can cause a flare-up of pelvic inflammatory disease if you don't wait that length of time. But I think 3 months is perfectly adequate to wait.
Perfect. Okay, so let's press back on with the presentation.
Okay, great. Which is nearly at an end, Rob.
Oh, super.
So yeah, so look, the last thing to talk about is laparoscopy. Now, and I know as a GP, you're not going to refer somebody saying, oh, you know, this woman, they're going to suggest, say, please could you refer this person to, they may need a laparoscopy. But certainly if there are comorbidities suspected, such as endometriosis or pelvic infection, or even if you've come back, you've got an inconclusive hysterosalpingogram, then of course you need to refer for a laparoscopy because that patient needs further investigations. And you know, a laparoscopy should be done as a see and treat approach. So any hospital should be actually taking a look and treating at the same time. So they take a look, there's endometriosis there, they will or should be treating it. So of course, if you're suspecting something in the pelvis that may warrant a laparoscopy, then early referral is advised. So, last
Super.
Slide, Rob.
There we go, in summary.
So, to summarise what I think, you know, when to do investigations, when to refer, it's got to be a common sense approach. And I think the important things are age of the woman. That's really, really important. You're never going to ask a woman who's 38 to wait 2 years or you know, or longer, because then they're going to be even older and their chance of success is less. The length of time of trying is really important. And you know, any couple that's been trying for more than 2 years really, you know, should have further test investigations, and absolutely is most likely to end up having fertility treatment. You know, you need to take into account aspects of the medical history because they may point to a specific fertility issue. And lastly, you know, it is you do need to take into account the needs of the couple. So some couples really, really just want to know if everything's okay, and others really want fertility treatment sooner than later.
I suppose one of the big points here is the GPs here tonight will be sitting in practices in different primary care trusts, and different primary care trusts will have different funding requirements.
Absolutely.
So you will all have different reasons to refer into the fertility clinic sooner rather than later, rather than going into the NHS for their own fertility treatment.
But I think, Rob, also to talk about, because I did work in the NHS for a very long time. And one issue, of course, even seeing couples in the NHS, is how long it took them to get from the point of being seen by their GP through to the point of having fertility treatment.
Great.
And you know, that time frame for some couples can make the difference between getting pregnant or not, because we know for fertility treatments, the success of fertility treatments, particularly IVF treatment, is determined by age.
Absolutely.
And I think it's really important to be conscious of that. So yeah, you know, it's great for those couples who've got NHS funding if they can get into and get their treatment as quickly as possible. But what we don't want to see is couples waiting for ages to even get the NHS funding. It
is incredibly frustrating myself, having friends who are currently going through fertility treatment. I'm very lucky to be sitting in a clinic with all the facilities around me. But to hear they have to wait sometimes 3 months for a consultation, another couple of months for their investigations, and then by the time they get to the actual IVF side, it's 9 months, 12 months down the line.
Sometimes years.
Goodness.
Yeah. So yeah.
Some more questions here. Great, thanks. You found that answer very helpful, Dr. Driscoll. We have another question here saying we have had patients requesting metformin for PCOS to improve their fertility. Is this something that is recommended to initiate in primary care?
There's been lots of work looking at metformin, and I can remember back in years ago when metformin was first introduced, as it's going to be the one to drug polycystic ovarian syndrome and ovulation. And in fact, sadly, it didn't quite turn out to be that way. And I think when dealing with women with polycystic ovarian syndrome, you've got the classic two types. You've got your very slim patients, and then you've got your overweight patients with polycystic ovarian syndrome. And again, metformin has been used to perhaps potentially improve or help with weight loss. Overall, sort of the final consideration for metformin has been that metformin may be of value in women undertaking fertility treatment because it may improve their treatment. But actually, has it been shown to improve pregnancy rates in natural ovulation? Actually, it has not. However, I think in general practice, as in lots of cases, you're under a lot of pressure to try and do something. And giving metformin to patients with polycystic ovarian syndrome is certainly not detrimental. It's not going to cause them harm. But I think they need to be aware that it may also do nothing, and because the evidence suggests that it is of greatest value or even of any value only in women when they undertake fertility treatment.
Perfect. So there's no more questions here. We have had a few questions submitted when you were signing up. So one of the doctors has asked, can I refer direct? So what's the advantage of referring patients directly to a private fertility clinic?
Okay, yes, of course. You can refer direct to a private fertility clinic. And I suppose one of the advantages of referring direct, we don't have a waiting time to see patients immediately. And of course, if those patients need investigations, we can do it really quickly. And of course, if patients need treatment, we don't have any waiting time for treatment.
Absolutely. We have 3 consultants here at the clinic. We have 12 nurses and a scientific team. We're able to support patients through the pathway very quickly and efficiently, providing a very high level of care at the same time. We have had a few more questions come in whilst we've been talking. Are there any recommendations other than folic acid for pre-pregnancy?
In fact, no. Although, of course, folic acid, of course, is for prevention of neural tube defects. And in fact, we recommend patients also have vitamin D, mainly because of the increased risk of osteoporosis in pregnancy. And we know that lots of women have low vitamin D levels. Vitamin D is an interesting vitamin because there is lots of talk about its association with spermatogenesis, so vitamin D for men, and oogenesis. But certainly the recommendation is made on the basis of becoming pregnant.
Super. I hope that answers your question, Dr. Palmer. Question about clomiphene.
Clomiphene. Now, clomiphene and the use in primary care. So clomiphene can, of course, be of huge benefit in women who don't ovulate. And in women with polycystic ovarian syndrome, a lot of women will ovulate with clomiphene. The recommendation, however, is that on the first cycle that women use clomiphene, they should have an ultrasound scan to monitor the cycle to ensure that, firstly, they are going to respond, and secondly, that they don't over-respond, so there's no increased risk of multiple pregnancies. So I think once a patient has been prescribed clomiphene and has one cycle of monitoring, then I think it is perfectly safe for GPs to prescribe it subsequently, but they do need to have at least one cycle of monitoring to see how they respond.
Perfect. We have a question here from Dr. Agarwal again, saying, do you have a leaflet explaining the approximate costs of different procedures at your centre for patients that we can use to advise them? Yeah, absolutely. We have plenty of price lists here. We can send these out to you, whoever may want them. We won't canvass you all with them. So Dr. Agarwal, we can contact you after this webinar and we can send you our price list on so you can pass these on to your patients. What I would say to you all is here at the clinic, we're quite happy to speak to patients rather than come in for an initial consultation. They can book an informal visit with myself or one of the nurses. At this stage, we're quite happy to talk through cost, basic fertility treatments for patients. That's at no cost to your patients. After that, they need to come and see the doctor to have, such as Dr. Tozer here, to have the investigations done. But we're quite happy to have chats with any of your patients on a very informal basis. You were going to say, sorry?
I was going to say also we have a patient information evening that we run as well, that patients can come along to, that we do. It's nice and informal. We do a short presentation, and then the patients do have the opportunity to ask questions from the lab, from Rob and myself, one of the consultants there, and the nursing staff are there. So that's a really useful evening as well. There was another question, just a bit further up in case we miss it, just that question on what drugs reduce female fertility. In fact, very little reduces female fertility. I mean, even patients who've gone through, cancer therapies, having chemotherapeutic treatments, will retain their fertility in many cases. So interestingly, the fabulous thing about the ovaries are those eggs are nice and in a nice quiet state. So there's very little that actually will reduce a woman's fertility other than pelvic irradiation or certain chemotherapeutic agents.
Perfect. Dr. Driscoll, of course, we'll send you a price list as well. And Dr. Krishnan's come up with a nice question here. She has patients who are pregnant from IVF already. Does progesterone suppositories reduce the risk of miscarriage?
Well, again, progesterone use and miscarriage has been one of those things around for years and years and years. And certainly with IVF treatment, it has been shown very clearly that patients need to continue with progesterone support until at least 6 weeks of pregnancy. Now, the reason for that is because when they go through their treatment and they produce good egg numbers, there are sudden and rapid changes in their hormone levels. And we know that from lots and lots of studies that there may be insufficient progesterone produced by the ovaries to support or to maintain a pregnancy. Now, that's very specific to IVF treatment. And we often will continue progesterone support through to 10 weeks of pregnancy until placentation has occurred. In other words, the placenta has fully taken over. In many ways, it's not an absolute necessity, but very reassuring for patients. There is still no clear evidence that giving progesterone support beyond 6 weeks will prevent a miscarriage. And for a lot of women, who think, oh, I have a luteal phase deficiency and that's why I'm not getting pregnant. A luteal phase deficiency, again, is very difficult to show, but a lot of women, and we do use a lot of progesterone for luteal phase support to try and improve pregnancy. How much does it help? I think it's debatable.
Interesting. So that's the end of the questions we've had from the webinar guests at the moment. Just running through this. What are the stats for IVF, depending on who has the issue? Well, really, so more importantly, it's not necessarily about what the issue is. It's all of our stats are presented by the age of the patients. If you're under 35, you have the very highest success rate because your eggs are younger, they're better quality. And as you get older, the pregnancy rates decline. What we can do is with the price list or any other information you like, we can send out results pages and you can see how successful IVF is. It's getting more and more successful. However, when you pass that 40 barrier, the results do not improve dramatically anymore because the quality of the eggs has already been affected by the age. Right, there's another question coming from Dr. Bankat. Can loop diathermy cause cervical incompetence?
So loop diathermy or LETS has not been shown to cause cervical incompetence because you're performing a loop, you're not going so deep into the cervix to affect, if you like, that sort of strength of the cervix that maintains or the competency of it. Originally when we used to do cone biopsies, well, these are deep incisions into the cervix that will affect the competency of the cervix, and there's no doubt that cone biopsies can affect a cervical competency, but loops not.
Okay, and there's one final question we had before the webinar from one of the GPs. I don't know if they're here tonight, to say they have recently seen a younger patient, only 25, who's been trying for a year to conceive. What should I do? Do I refer them or advise them to keep trying for another year, given their age?
Yeah, I mean, that 25 is young, and actually for me, the young people are more worrying because, you know, young people you would expect to get pregnant. You know, 12 months, ovulating regularly, they're young. And I think actually I would refer that, certainly after 12 months, I'd refer a young person in for investigations because actually they are really the ones that should be pregnant.
And we treat lots of very young patients here in the clinic, and it's very surprising to see what kind of infertility factors affect these young patients. And it can affect anyone at different stages of their life, but you only find out once you start trying to conceive.
Absolutely.
Super. Well, I hope you have all benefited from tonight and you have enjoyed the presentation. Thank you to Mandy for dedicating her time to provide you with all this wonderful information. I've certainly learned quite a lot today, even though I've been working in IVF for a long time. We are very pleased to have you all. If you do have any further questions, feel free to email them over after the presentation. And if you have any desires for us to talk to you about more of results interpretation, analysis, different blood tests, we'd be very happy to do that.
I think if people have a very particular interest in different aspects or something, then let us know, because there's so many facets to fertility.
Likewise, if you're local to the clinic, and you would like to come in and see what an IVF clinic looks like, then by all means get in touch. You're more than welcome to come in. We can give you some more materials for your patients, and it'd be a pleasure to have you here at the clinic.
Yeah, absolutely.
Super. Anyway, everyone, it's a lovely evening outside. Go and enjoy yourselves, and hopefully see you again soon. Take care, everyone. Bye-bye.